Thank you so much for coming today. Welcome to the Grand Rounds on IPE. I have two announcements, or two things I want to bring up before I get to introduce our speaker today. The first is to let you know about an upcoming Grand Rounds on October 30th, Thursday, October 30th, at the same time, 11:30, with Dr. Judith Haber, who has done a lot of work on IPE with oral systemic health. She is nationally known. She's from NYU, and she's created quite a program integrating IPE into their nursing graduate program there. I hope you can make that. There'll be a flyer going out shortly about that. The second thing I wanted to remind you of was the tip sheet that you may have seen at the front desk. And Dr. Marlene Sefton has devised this tool with Dr. Mamuna Hasnain from Family Medicine. So I'll let her talk a little bit about it.
Thank you. Hi, welcome. I just wanted to highlight this just for a second. This is a work in progress. So if you have any ideas or thoughts or comments about it, please let me know or let Jean know. Or email. My email is marsmith, MARSMITH @uic.edu. So this is what the intent of this is in the IPE literature and resources. There's a whole lot of stuff on how to facilitate an IPE experience for students when you're in the hospital. So you've got social work down the hall you can call. You can go call the pharmacist. He's coming on down. The med students are there and the resident. Everybody's there, right? Well, when you're doing experiences out in the community, in a regular community practice, community health center, FQHC, anything like that, I didn't find any way to help preceptors facilitate or students to understand how they can have an IPE experience when there's more than one discipline in that community setting. Now, granted, there's probably not going to be a whole lot. It might just be an advanced practice nurse and a med student or a resident, or maybe a PharmD student or something. But I developed this with the help of Mamuma, and we try to give some insight for preceptors on how to orchestrate that day in an outpatient kind of setting where all sorts of resources weren't around. So that's what this is. It is based on the competencies of the domains for IPE education, and you can see that each of the throughout the day orchestration parts, they're reflective. The superscript reflects back to the competencies, so you can see where you're kind of meeting those things. But anyway, that's what this is about. So again, it's not hard and fast. So if you have any ideas or something that you think needs to be added, please let me know.
We appreciate that tool. This is where we are now with IPE. We're at the point where we want to try to integrate it into the clinical setting. And our guest speaker today is Dr. Kathy Rugen. And many of you may know her from one role or another. Our VA visitors know her as Associate Chief Nurse of Education and Research at the VA hospital right here across the street. But I don't know if they know that she is also a nurse practitioner consultant for the VA Centers of Excellence in Primary Care Education in Washington, which is another hat she wears. And then additionally, she's also a clinical assistant professor here at the College of Nursing in our Department of Biobehavioral Health Sciences, where she teaches and works with students as well as precepting them at her clinical site. And I just learned that this is only her IPE stuff that she does. She has a bunch of other appointments and roles that are also consistent with her work at the VA. So very busy lady, and we're glad we could manage to get some time from her today. She has published articles, and also many presentations have been given by Dr. Rugen, primarily on the topic of IPE, Centers for Excellence at the VA, and integrating IPE into our educational curriculum. So I will help you welcome Dr. Rugen today.
Thank you, everyone. Thanks for coming. Thank you, Dr. Berry and Alexis Adams-Wynn for inviting me and coordinating our time here today. I just need to get a little acclimated. Here's the mouse. Okay, here we go. So our learning objectives today, I'm going to spend a lot of time talking about the VA Centers of Excellence in primary care education, and that's an important piece that it's primary care, so that's our focus. And I think that at the end we can have some conversation and talk about some key elements of an ideal interprofessional learning environment, and I'll talk about some of our lessons learned. Also, I hope that we can identify some curricular enhancements for nursing academia that would help improve nursing students, particularly in the case that I'm going to be talking about is nurse practitioner students for IPE in the clinical setting. And then describe 3 areas in which academia and practice could work together to really advance IPE. So why IPE? And this may be a very familiar document to many of you, but this is from the Institute of Medicine, Crossing the Quality Chasm. And I'll just read this real quickly. It's clear that how healthcare is delivered is as important as the care, is what care is delivered. Developing effective teams and redesigning systems is critical to achieving care that is patient-centered, safer, timelier, and more efficient and equitable. Equipping a workforce with new skills and new ways of relating to patients and each other demand both retraining of current health professions workforce and interprofessional learning approaches to prepare the future practitioners. So, quite a while back, 2001, I think we're still working on it. So some other documents more recently that came out, well, I mean, after that Quality Chasm report in 2002, then the IOM came out with Health Professions Education, A Bridge to Quality, again, where they stress that patient-centeredness and interprofessional education. The American Association of Colleges of Nursing, integrated interprofessional collaboration, behavioral expectations are in the BSN Masters and Doctoral Essentials. The physician education, the ACGME, and the American Board of Internal Medicine also included interprofessional collaboration in the milestones for physician residency training. So, here we see our professional educational organizations including interprofessional education, so that's a good thing. And then in 2010, the IOM came out with the Future of Nursing, Leading Change, and they talked a lot about advancement of education, interprofessional collaboration, nurses developing the leadership to sit at the table with others in leadership in healthcare systems, specifically physicians, to advance healthcare. And then in 2001, and Marlene referenced the IPEC, or the Interprofessional Education Collaborative, and their 4 competency domains of values, ethics, roles and responsibility, interprofessional communication, and teams and teamwork. So certainly a lot of things else is going on kind of simultaneously. HRSA has funded the National Center for Interprofessional Education, and that is at the University of Minnesota, and they call their center Nexus. So if you haven't seen that or gone to their website, they do have lots of resources. A little bit different than ours is that we are focusing on specifically primary care interprofessional education, where there's more global about interprofessional education in general. And we've had quite a few conversations with the group there at the University of Michigan to further both of our missions. Did I say Michigan? I meant Minnesota. Yeah, sorry. So what's the definition of IPE? It's when 2 or more professions learn from, with, and about each other to enable effective collaboration and improve health outcomes, and that's the definition from the World Health Organization. I'm not going to read this next statement, but if you aren't familiar with these authors, they write prolifically about IPE, so that might be a good resource for people. So let me talk a little bit about the VA. Maybe some of you don't know the VA's background, but the VA has a statutory education and training mission. I mean, we are sanctioned by Congress to educate the future healthcare professions. It's actually the largest education and training effort in the United States. I think Kaiser is just like right behind us. It's affiliated with most of the medical schools, and there are over 40 other health professions that are affiliated with the VA, representing about 1,800 unique colleges and universities. In 2012, which is the most recent data that I have, is 117,000 trainees have been trained at a VA setting, whether it's a VA medical center, which there are 152 medical centers, and then there's over 900 other points of care from veteran service areas to long-term care domiciliaries to our community-based clinics. And that's for both paid and without compensation trainees. I'll talk a little bit more about that too. So that's the VA's history, is, background. We have to train the next generation of healthcare providers for VA and for the nation. Our hope is that when they do train within the VA setting, that they will, be recruited to come on board. And I mean, just a show of hands, who has had some of their learning experiences in a VA setting in their graduate, undergraduate, master's, doctorate? Okay, so about half of the room here. Okay, so we have this mission to train healthcare providers, and in April of 2010, the VA announced that it's changing how we deliver primary care. Primary care in the past has always been provider, mostly physician-centric. It's, when the physician's available, and, all the things you read about access and all those issues that I won't get into in the news for the last couple months or so. But so the VA has put into place a model very comparable to the PCMH, the primary care medical home. There was lots of controversy about that title being medical and home. People were getting confused. It's not care that takes place in the home all the time. So, of course, the VA has to come up with its own mnemonic. So it's called PACT. It's Patient Aligned Care Teams. That is our model. That really has some of the same foundations as a PCMH. It's about access. It's about care management and coordination, and it's about practice redesign. And I think different from PCMH is compared to our PACT model in the VA is that the physician is not designated to be in charge, because PCMH models, that is how they're written, is that the physician is in charge. So anyone can be in charge in the VA PACT model. And all of this is a foundation of patient-centeredness and systems redesign and improvement, and then technology space community. So we redesigned how we're going to provide care, and that's been an ongoing process in the VA. I think, depending on where you're at, it'll be very different on how it's been implemented. And as we say in the VA, if you see one VA, you've seen one VA, because they all look very different. Okay, so we developed this model of let's change systems, let's change how we deliver care, but we're also the largest teaching. But we didn't incorporate this redesign of PACT to include trainees. I guess we forgot about them. So this is our model from the Office of Academic Affiliation, is that we need, when we're having practice redesign, we also need to have educational redesign, because that is all going to impact the patient. And so we need to have it both a learning and a caring environment, and then this will have ripple effects to the, actually the point of care, the clinic setting, to the facility, and then hopefully to the academic affiliates and others outside of the VA healthcare system to look at changing. So this has been our model for our centers of excellence. So in 2010, there was an RFP released to develop centers of excellence. Their purpose was to develop and test innovative approaches to curricula related to the core competencies of patient-centered care, study the impact of new educational approaches and models on health professions education, to include collaboration, cultural shifts, both at the academic affiliate and within the VA setting, shifts in the educational priorities, and educational workforce outcomes, both in VA and beyond VA. And then we want to improve the primary care instructional strategies with emphasis on the workplace learning. So very, very lofty goals. So this is a 5-year project. So the request for proposals went out in 2010, and I see Dean Weaver here, and she read that RFP and said, let's do this. And so we had a group here from the College of Nursing and a group from the School of Medicine that worked together. And we were one of the 22 sites that submitted a full proposal. Unfortunately, we were not selected. Only 5 were competitively selected. Yeah, we were very close, because I got a chance to read those other 5. So now in my role now, and I was like, but at least I then now have had this opportunity to work with all of the 5 sites. So the 5 centers were activated in July of 2011 with their first training cohort. So we're now going, October 1 will be our 5th fiscal year, and it will be our 4th academic cohort. The core requirements was that each of these sites has a physician and nurse practitioner co-director, that it's jointly sponsored with engagement of the academic affiliate, and when we did write the proposal, our academic affiliates at UIC did participate in writing the RFP. And our primary training focus was physician residents and nurse practitioners, students, and others could join in, but that was the main focus. And then they had to be integrated into the interprofessional team in the clinic. So we call those teams teamlets. So that's a teamlet of the RN case manager, the LPN, and the health tech, and the pharmacist, and the psychologist or social worker. So it had to be integrated into the trainee is integrated in that team. And that there had to be a 30% trainee time commitment. And this was an issue for the physician residents. So as you know, physician residents receive the majority of their training in the inpatient setting. So this took a little finagling at some of the sites with their ACGME and RCC and all these other things have learned about physician training. So this was a $35 million project. The sites received $1 million per year, so they're getting their last $1 million for 5 years of the operation. The trainees are also receive a stipend that's outside of this $1 million. And then there's a national coordinating center, which I'm the nurse practitioner consultant. I have a physician partner, and we're actually in this last year bringing on a pharmacy and psychology consultant. We also have an evaluation team, and we've kind of struggled over time with our evaluation team. So I can maybe tell you a little bit more about that later. Okay, so who are our 5 funded sites? They are at the and I have pictures here, and so they're not in any specific order. The San Francisco VA Medical Center, whose academic partners is UCSF, both medicine and nursing. The Boise VA, which was, I think, very interesting because their academic partners are way, way, way far away. So their academic partners are Gonzaga School of Nursing, which is located in, I think, Tacoma, and they're in Boise, Idaho. So it's a good ways away. And their medical partner is the University of Washington. So they're part of that. If you've heard about medical training in the Pacific Northwest, it's called WWAMI. So University of Washington is the only medical school for like 5 states. So they have this very extensive training program. Okay, and then the next site is the VA Puget Sound healthcare system located in Seattle. Again, the partner there is the University of Washington Medicine and Nursing. And then the Lewis Stokes Cleveland VA, whose academic partners are Case Western Reserve School of Medicine, the Francis Payne Bolton School of Nursing, the Cleveland Clinic Foundation, and then also they've expanded over time to include the Ursuline College of Nursing. And then our last site is at the VA Connecticut, and that's in West Haven, Connecticut. And their academic partners for nursing are Fairfield University, Quinnipiac University, University of Connecticut, and Yale. And on the medicine side, it's Yale and UConn. So lots of academic partners that have expanded over time. So the implementation model has been, they have to have this leadership model of physician and NP co-director. The trainees have to be there at least 30%. In each site develop their own program, so there are five different training models, and then we have our coordinating center, and then we have these impact sites. If you go back to that eyeball shape, so we hope that at the point of care and learning, which is the microsystem that's impacted. So we also look at the mesosystem, that would be the facility and the academic partner, and then how have we spread nationally. So that's how we base our evaluation, and it's really a realistic evaluation, and it's learning to what works for whom, when, and what circumstances and why. So that's the approach to the evaluation. So as you can guess, that there's not lots of hard quantitative data from this project. In the RFP, it was stated that they had their curriculum that they would develop had to address these what we call 4 core domains of shared decision-making, sustained relationships, interprofessional collaboration, and performance improvements. So, and these were developed because they kind of are modeled after what PACT is all about and patient-centered care. So, in the pedagogy that they would use is that it was not just sitting in the classroom, sitting next to someone of a different profession, and that was interprofessional education. They had to go beyond that, although that's really easy to do, right? I mean, bring people together, give them a lecture, and then, then they go away. Maybe they know each other's names. But really, we wanted to focus it on learning in the workplace. Okay, so that's been a little bit of a struggle, and I think we've had gained some leaps and bounds. And then to include reflective practice, and reflective practice as an interprofessional team, but I think there needs to be some own role development, so it's also intra-professional reflection are some of the teaching strategies that are used. So I'm going to give you a few examples. So for shared decision making, this is where we've defined that care is aligned with the values, preferences, and cultural perspective of the patient, and the curricula should focus on communication skills necessary to promote the patient's self-efficacy. So motivational interviewing, everybody's trained on that. So from the faculty to the staff to the trainees. So in that's been all part of our PACT transformation. Some sites, and I've just put some examples here, the Ottawa shared decision-making curriculum and their skills have been incorporated into their training program. And then we also have evaluation, and just to point out a couple of them, the dyadic option has been used to look at how the trainee feels that they are using shared decision making, and there's also an aspect where the patient can be fill out a survey and also be interviewed to look at the if their care was based on their values, preferences, and culture. So each site is doing a little bit different of an evaluation because these models were developed individually at each site. So for sustained relationships, the care is designed to promote continuity, and the curricula should focus on longitudinal learning relationships. So this has been an issue for nursing, for nurse practitioner training, because you know, if anybody in the audience, a nurse practitioner? Okay, only a couple. Okay, if you think back to your training, I'll tell you what mine was. I went 1 day a week for 7 weeks to this clinic. I went then to another place for 7 weeks, 1 day a week, and kind of rotated around like that. I never saw the same patient again. It was just one patient after another, so there was no continuity to see, well, this was our plan of care. Well, and you didn't have the opportunity to evaluate the outcomes of that plan of care and to establish a relationship with the patient. So we're really trying to promote that, and some examples we certainly have are home visits where an interprofessional team will go out with a faculty member to make home visits. I know at the San Francisco site they always talk about their home visit to someone who lived on a boat, so they got a really good learning experience from that. Certainly using a lot of telehealth type of technology through secured messaging, through video to an outpatient clinic. So lots of different ways to help sustain relationships. Certainly shared medical appointments would be another one outside of that direct one-on-one. For interprofessional collaboration, this is where we've defined the care as team-based. It's efficient and coordinated, and the curricula focuses on developing trustful collaborative relationships. One of the sites brought in the University of Toronto, their Center for Interprofessional Education, who did like a 3-day-long training for faculty, staff, and the students. All of our sites have employed team steps that through the AHRQ, I think it was developed by the DoD. So and they have some evaluation tools there that we can that you can use. Huddle and coaching programs, having huddles at the start of clinic or when there's a sentinel event or at the end of clinic. It's a way to certainly bring the team together. At our sites, at several of the sites, they have the NP lead the huddle, the NP student, and then shared medical appointments. I think all our sites are using the team development measure to evaluate the interprofessional collaboration that the trainee staff and faculty. For performance improvement, this is where the care is designed to optimize the health of populations, and the curricula focuses on using methodology of CQI in redesigning care to achieve quality. So this is where they do a lot of management of panels. So they look at chronic disease entities, the usual suspects of, hypercholesterolemia, diabetes is certainly a big one, those who are smokers, so that they look at a panel and they determine ways that for this population of diabetics on this panel, that they can improve their health. A lot of training has gone on for Six Sigma, Lean, at our Cleveland site, they've used the business school there at Case Western, and all the trainees have yellow belt training in Six Sigma. The IHI Open School, that is readily available and free for everyone, that they also sites have used that curricula to teach about performance improvement. We have identified that this is a skill that's lacking for the faculty. So when, we're like, where's your performance improvement curriculum? They're like, we don't even really know what that is, even to teach, the plan, do, study, act cycle, and then, how to, teach that to the trainees. The faculty were themselves very novice and uncomfortable with that. So what we did was put a 5-site group together, and our physician consultant who has expertise in Lean Six Sigma performance improvement, had them work together, and they're all, actually every site is presenting at the IHI conference on their shared topic. They were looking at reducing ER visits by patients who were in the clinic, and they all went at it a very different way. So it was very interesting that they all had the same goal in mind, but how they got there was quite different. So who are our trainees? Really kind of differs by site, but our core, each site, all the 5 sites have physician resident trainees at various levels. They have nurse practitioner trainees. They have students at a pre-master's and a pre-DNP level. Just one site, the University of Washington, does not have a NP master's program, so those are DNP students. And then 4 of the 5 sites have postmasters NP residency programs, and at the Seattle site they have a post-DNP residency, and I'll talk more about that in a little bit. All sites have pharmacy, post PharmD residents, and then post Psych D or PhD fellows. And then some of the sites, and I think our San Francisco site has had the largest and most diverse other trainees that have been involved, from social work to med students to dietetic students, podiatry, undergraduate nursing students. And only one site at West Haven has engaged physician assistant trainees. Again, the mandated was the physician and NP trainee. So what have we learned over these now going on 4 years is that, having the trainees who will be delivering primary care, learn and work together to prepare them are the ones you need to put together. Kind of no-brainer. Interprofessional clinical staff and the academic faculty need to collaborate across professions, and that's been a little bit difficult, especially for like our clinic nurse case manager. They're not used to having all these trainees. They're not used to precepting, and we really want to get them all engaged. The academic affiliates certainly need to be engaged and involved, and we do have faculty from some of the sites come and precept at the VA clinic. Some sites have struggled a little bit with that. Others, and I'd say nursing is the most engaged from the academic side in helping them with developing curriculum. In the areas that they're, like the motivational interviewing is taught in several places by nursing, the School of Nursing affiliate. And I put this picture there, but you really need to understand the others' professions, their culture, their values, and their educational trajectory. I found physicians really struggle with the nurse practitioner's educational trajectory, and I remember being on one of the site visits, and the physician co-director was like, "Now I like NP students like medical, M3s." I'm like, I have no idea what an M3 is like, so I can't answer that in the end. And the NP students were like, why are they trying to put us pigeonhole us into this box of medicine? So obviously we still struggle with that. And we really want to have sustained relationships, you know, the trainee with the patient, the trainee with their mentor, the patient with the mentor when the trainee's not there, the team with the RN, the LPN, the clerk, and then the other trainees. So we got to have them there on the same day, at the same time, so they can have a relationship. Very difficult to do. So interprofessional leadership has been a struggle. So when we first put out the RFP, it said that there has to be a director and a co-director. And we changed that model at the first time we came together. And I can tell you a little bit about my experience here at UIC when the dean of the School of Nursing, Dean Weaver, brought people together, and she invited people from medicine to come over, and they got a physician who had an appointment at the VA to get involved, and they said, well, he'll be the director, and you can be the co-director. I'm like, okay, you don't even know who I am. I'm the one who initiated this process. So it was very interesting. So at our first meeting back in March of 2011, it was like stand up and introduce yourself, and all the physicians out of the dyad stood up and said, I'm the director. So that was very, very interesting. And what's very interesting about our program is that they're all female with the exception of one. So I don't think it's a gender thing. And we've had very, very senior physician co-directors and very junior co-directors. So it's been interesting. And then all of the MP co-directors have been female. So right then by our chief officer in Washington at the Office of Academic Affiliates said, we're changing this model right here and now. It's going to be co-directors. You're going to be partners in this. And that has been a struggle because in several of the cases, you know, the physician's been there for, 35 years. They've led the residency training program. They're the go-to person. They know how to deal with HR and all these other things. And the NP's been the good NP in the clinic and is a great clinician, but hasn't had these opportunities to learn how to run programs. Let alone evaluate them and all that. But I'm getting ahead of myself because that's for our discussion. But so it has to be these leaders are present when critical decisions are made that really affect the running of an educational program such as space and staffing and design. And they have to be there, developing curricular elements and really renegotiating the roles, responsibilities, and not relying on the hierarchy, which has been the physicians in charge, is important, but it's certainly been a struggle. I think we've come a long way, though. And we really need to engage all the members of the team. I know one site has their LPN run the huddles. So when they scrub panels, it's the LPN who's there going, this is Mr. So-and-so coming in, and this is what their diagnosis is, and this is what they need. Other places have the NP student do that. So varies from site to site. But we have to engage all of the members to really have meaningful roles, and that they really need to be involved in assessing the learner's performance. So some of the structural components that have certainly been challenging. So when we have the interprofessional teams there together, it's really creating a cohesive learning environment among the programs with different academic calendars. Really, it's only been the NP student who is concurrently taking classes, writing papers, taking tests. The physician residents are done with that. The psychologists and the pharmacists are done with that part of their training. So it's really the NP student who kind of has that learning curve also. So how do we sequence the formal instruction, and I'll give you an example on that. So there was formal instruction being done on one of the sites on shared decision making, and they used an example of a patient who had hepatitis C. And so they were using that and talking about treatment to learn some of the techniques of shared decision making. Well, I guess the NP, what I was told is that the NP trainees were so nervous, embarrassed, and at the point crying at the end because they didn't know about Hep C and Hep C treatment, and they felt that they needed that information before they could really engage in learning about shared decision making. So they changed it from Hep C to be something much more simple that would not put people on edge. So when is the sequencing? And then actually at this the same site, and I'll tell you who it is. It's at the Seattle site. They had a great model. We loved their model. Is that they were going to, so they had the BSN to DNP, so it's a 3-year training period, and then they had the physician residents who would be there, year 1, year 2, year 3, to bring them in as a cohort year 1 when we first started. And so the NP's students had nothing. I mean, they didn't have any of the 3 Ps. They didn't have, management courses. They didn't have pharmacology courses. So the expectation was, that they were just so beyond the physician resident learning curve that they had a very difficult time bringing them together in formal instruction and certainly in the workplace. So it's really getting that right mix of, profession, academic level at the right time. So what they did the next year is that they switched their focus on the DNP 3rd year students, that they were kind of more at a level of comfort, had their core, physiology, pharmacology, pathophysiology, physical assessment courses. So that was better for them. Certainly there's intraprofessional challenges for nursing the NP students, that most of them are part-time trainees. Whereas all the others are full-time trainees. They may be working full-time, going to school part-time, and that they have these concurrent classes and clinical rotations. And for medicine, they have all their ACGME requirements. They have to go, to this specialty, to that specialty, and so on. And that really causes a lot of discontinuity in the model that we want a longitudinal learning experience with developing sustained relationships. So those things are certainly struggles. Space has been a huge issue, especially at this site. This is our West Haven site, and they're doing a didactic program. That's our physician co-director up front, standing up front. And so it was a very nice space that's right there in their clinic, and the facility said, you can't have this anymore. So they had no space to do any of this very nice training. But it's really important, and on the perimeter of the room they have computers. When they do precepting, they do dyad precepting there, where they have a physician and NP faculty precept physicians and NP students and NP residents. So really having everybody together really enhances the ability for learning together, learning from each other. Certainly having enough exam rooms is also very important too. So these structural components really of space are really important. The other thing is technology that some sites have struggled with a little bit. Is having the trainees have 24-hour and off-site access, and so that they also the ability to say, well, this trainee saw this patient and this is their faculty and this is their staff, to kind of match them up and look at outcomes of these training models. So that has been a little bit of a of a struggle also within our own VA, how we track patients. So what have been some of our innovations? We have gained protected time for all precepting and supervision for all professions, and this was huge for the NPs. If you think of the physician training model, that attending physician is not running around seeing patients while they're precepting and supervising the physician resident, right? I mean, I see that every day in my clinic. But what's the NP doing, and I do this, is that I'm behind closed doors seeing a patient while the NP student is behind closed doors seeing the patient. And then, we meet and, what type of learning experience am I providing and mentorship. So we have now protected time, very commensurate with the physician precepting model. And all the trainees have been assigned to this teamlet, and so they do have also a mentor for a longitudinal learning experience. All our sites have 1 year long NP students. They come about 2 days a week. I know at UCSF those students sign up and say, yes, I will be here 2 days a week, every week, except for when I have to take a test or something. So they sign up and know what they're getting into up front. We've done a lot of interprofessional co-precepting. The West Haven site has a model from day one of a dyad of physician and NP precepting all students. Some of the sites have worked to have like the 4 core faculty precepts. So you have pharmacy, physician, psychologist, and the NP there for any of the students of any of those professions. It's hard to do all the time, but, I'd say some sites are up to like 40, 50% where they'll have the whole faculty there. And we pay for that, the faculty, that support. We have, all our sites have been built on physician training. So they've really revised it to be an interprofessional training curriculum developed by the interprofessional faculty. The trainees work together on quality improvement projects. So I told you about the one with the ER visits. Trainees have been working on those projects to reduce ER visits. At one of the sites, the trainees led looking at opioid use, and they decreased the amount of opioid use in that whole clinic's panel of patients, which is about 3,000 some patients, from 14% to 7%, and the cost savings with that was, tens of close to hundreds of thousands of dollars. So they've made a great impact on, the system itself. We have NP students and NP residents sharing a panel of patients with the physicians. Residents, so when the physician resident goes off to, do their in-house rotation or their ICU rotation or their whatever else rotation, the NP is responsible for that panel of patients, and then they communicate back and forth by text and email and all those other things, although the HIPAA requirements, they can't say a lot of things. And then we've also, all of our 5 sites have NP residency, and I talked to Susan Corbridge earlier today, and the name residency has been a big issue. So when we first started, our first site at West Haven called it an NP fellowship, okay, and then we spread to the other 4 sites, and one of the other sites also used the word fellowship, but the 3 remaining sites used residency. And I think that was the physician was saying you can't call it a fellowship because they wanted to equate this training time with like doing a physician fellowship. So if we have time, I'd like to hear your thoughts on semantics of residency versus fellowship. I know NOLF and other NP organizations have put out a statement saying it should be called fellowships. Again, we had, we said, fine, you call it what you want, but then we did get together last May, right before that NOLF statement came out, and said, well, 3 sites called residency, 2 sites called fellowship. What do you think? And we agreed to residency. So go figure. But this is a 1-year full-time postgraduate training, so the 2,080 hours. We have both the master's and post-DNP. Just at Seattle was the DNP site. So these are new grads from NP programs. They are paid a trainee salary, so it's not a lot. It's locality based. It could be 50 to 55,000, so not much compared to what an NP could go make when they are a new grad and get a job. But these sites have been, they have 4 or 5 slots. They get 30, 40 people applying to come into these programs. So people feel that there is certainly a need for this. And during the residency, they do about 60% direct patient care. They have an assigned panel of patients. They, at some places, share that with a physician resident. They have prescribing and ordering capacity because they have been certified and have their appropriate state license. They are considered a trainee, so they have supervision, and they have graduated supervision over time. And, they do lots of other things, shared medical appointments, certainly all the secured messaging, telehealth things that we do in the VA. And then they have been some other specialty rotations that they do. And one of our sites at Boise, they created an inpatient rotation for the NP resident, just so that they would understand, how patients transition from the primary care setting to the hospital and back. And about the other 40% is for indirect. They work on performance improvement projects. They do panel management. Other things they've done is journal club, presentations, publications. We've had lots of publications from our trainees. And then in the second half, the second 6 months of time, they will work with their mentor in precepting, developing skills. So it's really developing some scholarship and teaching acumen is the focus for that 40% of indirect time. So where have we gone? So in our first year, in 11 to 12, we just had 3 at the West Haven site, 3 residents, they were called fellows there. And then in the next year, every site, Seattle was a little bit behind. But by the time we end, we'll have had 44 individuals go through a residency program. So we are evaluating how they progress over time, and we've developed actually a competency tool. And so this is just some preliminary, just this, it's cut off at the bottom there, just some averages of all of in the aggregate of all of the trainees from the first 2 academic years. And we have several domains that they do a self-evaluation, and then their preceptor mentor also does an evaluation of them. So with the clinical competencies, some of the things we ask there are, able to perform comprehensive H&P, able to construct pertinent differential diagnoses, order appropriate screening diagnostic tests, order appropriate consults, order appropriate medications, perform comprehensive medication reconciliation. And then we go through the various types of common primary care disease entities that, hypertension, obesity, diabetes, depression, heart disease, COPD, and then some of the VA veteran-centric type of states such as substance abuse, military sexual trauma, suicidality, traumatic brain injury. And you can see that on the scale. So this is scale of 1 to 5, and 1 is that they can observe only. 2 is that they need direct supervision. 3 is that they need supervision periodically. and 4 is that they can perform without supervision, and 5 is they can supervise others. So that's the rating scale. That's based on the ACGME model of entrustable professional activities. So you can see that, when they come in that first month, they're not quite 3, so they're somewhere between needing direct supervision and maybe not always needing supervision. So they're in that kind of the clinical realm. They're a little bit low, certainly in the leadership domain. And then, I think performance improvement, which came off the slide, was also pretty low. Okay, so, and then you can see what really made me happy when I saw this is how comparable and how well, and we're doing some t-tests here on the correlation from the trainees rating to the mentors rating. So you'll hopefully be seeing this more in the literature. But so basically we've certainly had progression throughout, and we're also doing a qualitative analysis from the information that we've gotten from their 1 month, 6 month, 12 month self and preceptor rating. So we're in the process of writing those up. So what have the trainees told us about these centers of excellence? Well, that they really, really like meeting and learning about other professions. They value learning with and from other professions. So they like somebody of a different profession to come in and talk to them. They really value the team-based approach. They report that they can apply what they've learned to their practice. And the 2 things that were said, and these were from semi-structured interviews done by our evaluation team, is that they can really apply shared decision-making tools and motivational interviewing things that they've learned. And just kind of a fun quote from one of the trainees, and I don't know which profession this came from. This is an aggregate of all of the trainees, but that it just kind of insidiously crept into my day-to-day behavior. So they're learning these things and they don't know how or why, but it's like, oh, showed up. All right, and the trainees report, oh, you know what, I'm going to stop there. I have a video that I want to show you, and I almost forgot about it, and we made a big deal about getting it there. So at the sites, you were emailed the video. So if you just go to the, it's just 2 slides on a PowerPoint. If you just go to the second one. So I'll just tell you a little bit about this. It's short. It's like 2 minutes. First, you'll be hearing one of our psychology faculty at the Boise VA, and then you'll hear like a pair of physician pharmacy, physician nurse practitioner trainee from our West Haven site, just talking about their experiences in being engaged in these centers of excellence. So let's see if it works. So I thought that was very good to say that they're complementary because we struggled with that also at our sites from the faculty. So how can they role model interprofessional training? But we had at one site a physician held up a piece of paper and wrote MD equals NP and said, "What's up with this?" And it's like, no. It's not, we're not trying to say we're equal. The MPs are not here to take your job, but we're here to work as a team and to complement each other and to determine, who's the right patient for whatever the skill set is that we bring to the setting. So the trainees have also reported some areas for improvement, that they want more workplace learning, that they want more in the exam room precepting, that they want everybody to be on the same schedule. Hard to do, but they want it, so that's a good thing. They want everyone there. They still, even though they like working with other professions, and that is that they, want clarification of roles still. They feel they need that. Also, specifically to refine the integration of pharmacy, psychology, and social work. They were not our focus right from up front, so I think that's been a work in progress. And they want more peer-to-peer teaching opportunities, and some sites have excelled in this more than others where, it'll be the trainee who gives the grand rounds, it'll be the trainee who leads journal club, not the faculty. So made certainly some efforts with that. So we've had some sustainment examples. So one of the medical schools has really changed their whole physician trainee rotation block to be like the centers of excellence have, where they're there for 12 weeks and then go do something else for 12 weeks and back. So that has been a huge thing. That happened at Yale. I guess things don't change at Yale very often. So that was a feather in the cap of that site. Also, we've had the local School of Nursing restructured course schedules to accommodate NPs joining kind of on that off cycle. So they join when the physician residents mostly come on board is July 1. So instead of, that August, end of August or beginning of September, they actually did some crash courses for the NP trainees so that they can start, and they had them start in July. We have had retention of the trainees as faculty. I can count off the top of my head of 6 NP students or NP residents who have stayed on and have now faculty at the sites. And certainly the local facilities are now supporting some of the faculty salaries, so that's good. It's not being paid completely by the grant. Certainly the trainees are very enthusiastic about the program, and that really helps recruit other learners. I mean, for the physician residents, I know, they only take maybe like 12. I mean, they have like hundreds apply to go into the COE. So, there's not enough space, but so it's been really, really, just very impressive about the trainees. They get this. It's a no-brainer for them that they have to work in team, in an interprofessional team. And so it really has been attracting very strong candidates. So we feel that they're certainly wonderful, wonderful trainees that come to this. So challenges, certainly they're there. The traditional hierarchy of physician in charge, still there. Maybe in the individual themselves, but it's getting better. And these programs were built, as I said earlier, on the backbone of physician residency training programs. So they've worked to make that more interprofessional. So that's a work in progress. The leadership and operational developmental opportunities are really lacking for the NPs as compared to the physicians. They just haven't had that protected time to go to a leadership course. They haven't had the protected time to, make complex schedules. Go over to the academic affiliate and meet with them. Do some self-training. Those opportunities really haven't been there, and that's something, the VA we really need to look at. Let's see. Yeah, in some places, certainly patient care comes first, and always that protected time to work on curricula, to do other things is taken away because patients need to be seen. Certainly, it's been an increase in the workload and complexity for the staff, the nurse, the clerk, the LPN, the health tech. Now they have these 10 students on their panel in addition to the providers that they work for. Certainly, there's been the deterrence, and they vary by profession. The NP trainees experience constraints on work opportunities and a loss of salary. If they got to commit to 2 days of being, if they're a student in this clinical setting, where maybe they wouldn't really need all that, and then they can't be working at their job as an RN. So that's put some constraints, and certainly physicians, trainees may sacrifice other electives that they could have participated in. And then a challenge with evaluation is that this is, really small numbers. It's, more of a demonstration project. And, what do we have out there for educational research? It's not a very established science. So educational research is certainly a challenge. So what have we learned from our evaluations so far is that there are certainly contextual factors that facilitate or impede the program, really improving and maturing, implementing and then improving and maturing. It's the degree of how much is that PACT implemented. So do they have team-based patient-centered care? So how good is the care that they provide? Space is huge. And then the facility commitment, especially for giving that protected time for those educational roles. We really need to focus on faculty and staff development because they're going to have multiple teaching roles, from developing curriculum to precepting. And our faculty really need to model interprofessional education and patient-centered practices. So they need some development in that. Also important to match the curriculum to the trainees' clinical readiness and interest. I told you about that shared decision-making, Hep C fiasco. So, really matching to where the trainee is at. Certainly the curriculum's a work in progress, and really to get the right mix of instructional strategies. It's really easy to do didactic formal instruction, not so easy to do the workplace learning and reflective practice. So, but we've made great strides at that. And certainly, be mindful of burnout. I mean, we have interviewed some of our faculty, and, I just got an email from one of the site co-directors, and she's working at her facility, we're going into our next phase of this, and she's like, I have to not work like 75 hours a week. So I'm hoping our facility will hire additional NPs because she just can't do this. She's certainly committed to to the project and to the innovating and improving. So what are our next steps? We're working on standardizing the NP curriculum across the 5 sites. So we have representation of the 5 sites, and also that we're going to make this not so NP focused, but interprofessional focused, so that other disciplines could use the curriculum that we've developed. We're going to, as I said earlier, publish our competency results to date. We're looking at accreditation. I mean, you look at, PT and OT and pharmacy and physician assistants, certainly physician residents. They all have accredited residency trainee programs. We want to call it fellowship or residency. But they're all accredited. This is no NP residency or NP fellowship is not accredited. So we need to, we've talked with CCNE for the past 2 years because they do accredit, the CCNE does accredit post-baccalaureate residency programs. I think there's only about 9 or 10 in the country. There's actually two in VA. But, and then ANCC just came out this year with accreditation of both post-baccalaureate and graduate residency programs. I've looked at the book, and it's not a very rigorous process. So more to come on that. So the 5 sites are getting ready to recompete. We're writing the next phase of the RFP. And we're really going to focus on development of implementation kits that can be taken to other VA sites, outside VA sites, to implement some of the things that they have put together. We're actually standing up a packed work group that's going to start soon. We have representation from each of the regions. We call them VISNs. So we have 21 VISNs. So we have 2 representatives from all of the 21 VISNs that will come together as a work group to see how we can spread this this interprofessional education. Oh, sorry, I have two spread there. I'm just noticing. Sometimes you look at the slides and you can't see your typos. Seen them too much. But so I'm going to represent the Office of Academic Affiliations on the work group. We asked the regions to send an interprofessional team, and we listed, it could be, you know, all these different professions. Guess what we got? I'd say 85% are physicians. So unfortunate. So us non-physicians are going to have a very strong voice on the team. And there are other couple MPs, couple psychologists, 1 social worker. So, but the large majority is physicians, even though we said. So, you know, there goes, you know, interprofessional. And then we're also going to work on integrating mental health into the sites. So some things for the consideration of the academic setting is certainly flexibility in scheduling. And it's especially crucial, I think, at the very beginning when the cohort comes together. You know, I don't think we're ever going to change physician training, and they are the largest number, and they come July. When does everybody else come? Not usually July 1. So we have to have some flexibility in scheduling and to really get immersed into the clinic. And I think then, you know, they can kind of go away. I think we need to really have our students, and particularly the nursing students, you know, come to the clinic setting with you know, already well-versed in patient-centered team-based care concepts. I think, you know, they're going to be, you know, behind the learning curve from the clinical aspect, but I think if they can come with some strong, you know, non-clinical things, because they're learning the clinical things concurrently, but if they can come with strength in motivational interviewing, shared decision-making, which, you know, you think is, you know, that's kind of nursing 101 is shared decision-making, but from a really academic perspective, and how are we going to actually really do that and measure the outcomes. Certainly, you know, nurses could lead the performance improvement along with the panel management and population health. But, you know, when we go make site visits and, you know, we talk to the trainees, and they're mostly, you know, physicians, few NPs, few others in there. And, you know, the NPs will say, oh, I love learning with the physician residents. I learned so much from them. Oh, my God, they just come with, you know, so much knowledge. And I recall asking one of the trainees, so what do you bring to the table? And that's what I got. So if we can boost up what our trainees, what our nursing trainees, our NP trainees are bringing, I think that will make it easier for them to integrate. certainly these need to be longitudinal learning experiences. You can't just come and go. You need to develop relationships with your mentor, with other peer learners, with the clinic staff, with the computer system, with, the whole, how does it work? Because then you go to the next place and it works differently. So, and how stressful is that? So to, just be in the same place with the same people, the same patients, and be able to see how the patient progresses with your treatment plan. So is it when should NP students come into the clinic setting? Is it, they've had all that other stuff done? Or, do we say you have to be full-time? And, what's going to be the best? They have to come being that they're accountable and committed. They have to look at what's going on with the patient, when they're not in the clinic, because if they're assigned that patient, they have to be accountable for the patient. And what counts for clinical hours? Does doing SMA, a shared medical appointment, count? We got to count those hours. Does that count? Working on a performance improvement project, does that count? Some of the places, some of the schools of nursing we've had issues with because they don't count those things. It's just got to be behind the closed door, one-to-one with the patient. That's what counts. And then how many hours? It's only 500 clinical hours to sit for certification. We here at UIC, require a lot more than that, but is that enough? What is the number of hours? I think we need to look at. Certainly academia and practice can work together. I think especially with the NPs, they need leadership development. They need to develop teaching acumen. Just because you're a good clinician doesn't mean you're a good teacher, a preceptor. And certainly, we're developing a lot of curriculum, so, they have to learn how to develop curriculum, and we're developing the NP residency curriculum right now so that, and we're developing it as kind of a doing while learning. So, they really need some development. Presentation, public speaking skills, grant writing, writing for publication, program evaluation, instrument development and testing. Certainly, academia, especially nursing, could partner and help develop some of our NPs at the sites. And then here are some references, and I thank you, and I started late, and I'm just about at time, but just want to hear your thoughts, what you think. Open for any questions. Yes?
How does it work when you have the centers with the academic institutions? I don't know what states like. The students come to the clinic?
Yes. Yeah, right. So especially at the Boise site, we've had, students from Gonzaga's program, and their program is a distant program. Yeah, the student came from Alaska to Boise. So we've had, students come a great distance, and I think just in that part of the country, they're kind of used to getting their education and knowing that they have to go far away. So we do at that site have some rural training experiences for all the trainees to go out at a distance. I know that so Gonzaga's only had an FNP program, so for that student that came from Alaska, we also set up the, pediatrics and infant and other experiences that they couldn't get at a VA. So, but we're looking at changing, from a family focus to more the adult gero primary care track of NP trainees, because we want them to have that longitudinal experience. But yeah, and we actually have that site at Boise has budgeted for the NP and the physician co-director to go to Gonzaga, and for the faculty member that they're working with to come to the VA. So they put that in the budget for travel monies. So they do go a couple times a semester. The physician and NP teach up at Gonzaga, and then the faculty members working on some curriculum with them. She worked on transforming their physician curriculum into an interprofessional curriculum. And also they're working on cultural competence between the different types of trainees. So yeah, you put it in budget. So and hopefully now when there's not the budget there, that the facility and the academic affiliate will say, well, this is really important that maybe we're going to put the money there for it. Yeah. Sure. Oh, sure, sure. Yeah.
Original that is set up to evaluate graduate or see if this training and make a difference. Other untrained professional colleagues that are working with, if it's, effective.
Right. So we do have, in the VA system, we have an well-established learner perception survey, and we've tweaked that for just primary care. So all the trainees in this program take that evaluation at the end of their training period. And then we also have the cohort of those who are not in these centers of excellence. So we do have some comparison, although our numbers in this cohort are small. And we will follow them over time and see where they go and where they work and do some follow-up evaluation. Yes, that is built in. We have two PhD health system science evaluators who will do that. Yeah. Marlene? Yeah. Oh, I'm sorry. So that question was about built-in evaluation for follow-up in comparing the trainees who go through this program to others maybe who to those who haven't, and to follow them long-term. And I will post my slides. Yes, I'll ask Alexis to do that. And the video as well. All right, great. Well, I thank you.
And thank you so much, Kathy. It's really kind of exciting to hear about the success of your program, and also the perils and pitfalls that you mentioned are very important for us to know about as we go forward and look to our own sites and our own clinical opportunities for IPE. So thank you.
You are welcome.
Thank you all for coming.
Sorry for